scaffolds. But since I have 8 minutes, I'll try to convince you that's the right thing to do. Before I need to declare my disclosures, we do research with several companies. But again, the first lesson that we have to understand, of course, in the US, you're going to have Absorb for a few years before you have the second generation and before you have other BRS devices. But you need to understand that not all bioresorbable scaffolds were born the same. Some are polymeric, some will be metallic, of course, bioresorbable metallics such as magnesium. You're going to have different scaffold designs, and most are going to be non-radiopaque, so you have to rely on the radiopaque markers at the edges. And this is an example of OCT from our core lab that showed how OCT looks in terms of acute implantation after Absorb, after Dissolve by Elixir, after Phantom, after Mirage. As you can see, the shape of the scaffolds are different. Of course, Absorb and Dissolve are more similar, but this is the Dissolve with 120 microns, so a little bit smaller. You see that with Phantom, 125, but this is combined with iodine, so it makes it radiopaque. That's the only one that is really radiopaque. And Mirage with an oval shape that embeds better into the vessel wall. So there will be some nuances and difference that we have to understand when you have available all these devices in the near future. Also, in terms of long-term follow-up, you see that they behave different. Some will be resorbed a little bit faster than others. Absorb, it's 3 to 4 years. Dissolve, 1 to 2 years. So it's hard to see the struts after 2 years. Phantom, as you can appreciate here, it looks like a metallic DS, but it's bioabsorbable because it's combined with iodine. And Mirage, in 6 months, you don't see anything. So these are important features that you have to understand when you evaluate these devices. But as I mentioned before, those are perhaps the 3 items, the 3 Ps that you have to remember. Proper vessel sizing, very important, preparation of the lesion, and we have to pay very close attention to the expansion limits. If you take a 3.0 Absorb, and if you choose to post-dilate with a 4.0, 4.5 balloon going up to 20 atmospheres, there is a big likelihood that you're going to see some fracture of the device. Remember, these are methacrylate, this is PLLA, plastic material, not really metal. So there is some tolerance to post-dilatation. So in terms of proper vessel size, what we've been doing outside US, of course, you're going to have this device very soon, we hope, is we take the DMAX, we try to do QCA. That's very democratic. Everybody has angiography and QCA in every cath lab. So we try not to connect this technology with very fancy, sophisticated imaging. So DMAX is what we do. We take the proximal reference instead of the interpolated one, and we try to size this device, mainly after post-dilatation and after nitro. So you're going to have a more reliable measurement. This is an old slide that shows that probably OCT will be the best imaging to be more precise in terms of vessel sizing. IVUS generally overestimates a little bit and QCA underestimates. So keep that in mind when you choose your imaging modality to guide you to implant these devices. In terms of preparation of the lesion, we're going to have to be more aggressive. We try to do 1-to-1 balloon sizing with non-compliant balloon to prepare these lesions. And I think that Mount Sinai will be #1 site in the States to prepare the lesions, very aggressive. As you saw, a lot of liberal use of rod ablator, cutting balloons. So I think that's the message, to put these devices that has less radial force. And these are some recommendations that I'm not going to read through. We have to pay attention to, of course, expansion limits. What we do with Absorb, we inflate the balloon every 2 atmospheres, 10 seconds, to accommodate and slowly. And after we get to the nominal pressure or to the average pressure that you're going to use to deploy, we hold that for 20 to 30 seconds to make sure that the device is well accommodated and the polymer expanded properly. And again, try not to be super aggressive because of rupture. And this is because of fracture. And this is the nominal pressure and the rupture pressure, which is 16 for most of the sizes that we use with Absorb. And again, if you use a 2.5, you can easily post-dilate with a 3.0 with high atmospheres. Nothing's going to happen. So that's the formal recommendation that the company will write in the IFU. Very important to identify the markers at both edges to avoid geographic miss, particularly for post-dilatation. So stay within the markers so you're not going to cause injury at the edges. Also, you have to accept the fact that the result immediately post-implantation is not going to be as perfect with the metallic scaffold. Remember, this first generation devices are 150 micron, and you're going to have the impression that you have a little bit less residual stenosis as compared to metal. It occupies a little bit more room inside the vessel, and without the visual identification of the metal, you're going to have the sensation that you have a little bit more residual stenosis. Finally, some special situations, bifurcation, multiple scaffold with overlapping, tortuosity, calcified lesions, can be used in this kind of situations. Yes, I wouldn't recommend in the early experience when you start to use these devices, but if you do very careful lesion preparation, you can do. For bifurcation, we analyzed the absorb extent registry. We learned that there is a little bit more CKMB leakage minor when because we close a little tiny little side branches. But again, not the leakage was very only limited to 1 to 2 time folds. This is a bifurcation lesion that we choose to use an absorb, and you see that most of the side branches are preserved with this technology. This is again another bifurcation with some disease at the osteo of the diagonal, and this is the result post. We went ahead, very gentle kissing. We cannot use a balloon, a side balloon greater than 2.5 to optimize these results, and you see a very acceptable result. John Armstrong did an independent analysis, essentially saying that after more than 10 atmospheres should not be advised with a 3.0 balloon in the side branch to have access. Overlapping, again, very important to pay attention not to overlap too much. The data doesn't look bad at long term as long as you do a good job with it in the beginning. Tortuosity, I think that we can do some patients, of course, with more challenging anatomies. This is an overlapping case with 12-month follow-up, very good result. And again, this is a thematic case that I did for TCT, and this is the result after 36 months. You really keep the shape of the vessel and preserve the anatomy, as you can see in both QCA and by OCT. Finally, this is the last case with a young lady that had a CTO, a total occlusion of the right coronary artery, a lot of calcium. And this is the finding before. We did more aggressive, we managed to cross this lesion, a lot of pre-dilatation, more aggressive with the 3.0 balloon. This is the result immediately post pre-dilatation, so we have to have less residual stenosis to go ahead and deploy, in this case, multiple absorb scaffolds, 3.0 by 28, 3.04, and this is the result immediately post. So I think those cases are feasible, but I would stay away in the early phase of your experience. And again, if you do that, make sure that you are very aggressive with pre-dilatation. So the take-home message again, pre-dilatation, vessel sizing and post-dilatation. Thank you so much.